Hello, everybody. Thank you for joining me here right now. So, thank you again for all those uh, therapists who watched my first webinar about practical tips prior to migrating or starting your US practice. I really appreciate the feedbacks, guys. So, someone asked me about evaluation and, in general, documentation. So, I figure I can make a general overview of how it is. I know for a fact that when I was in the Philippines, the documentation is very different than the documentation here in the US. And we're going to discuss just the general overview. I'm not going into details because there are so many factors that affect the kind of documentation and the information that you need to gather during evaluation, depending on your setting and depending on what kind of software your company will be using. Okay, so my name is Ginaline. I go by Jing, like Jingle Bells. Ruder, I'm a physical therapist. I used to be a review lecturer again in the Philippines. And it is my desire to go back to teaching again. So I've been making some of these videos for a new generation of therapists coming over here to the US just to help out and share my knowledge. I know it is a struggle if you're starting, and anything will help you get started easier. That is my goal. I will be planning on doing online courses as well for those of you who will be interested in signing up for that in the future. So I'll let you know about that. Okay, so let's dive in. So document for evaluation in general. So for physical therapists, like me, it depends. The duration depends on your setting. Um, the It can last from 60 minutes or an hour, can be 90 minutes or 2 hours, So again, it depends. Like you're seeing here on the slide, in my home health setting, I'm only given 60 minutes to do my entire documentation. So 60 minutes kind of tight, really, to do a very comprehensive documentation. In my inpatient hospitalization, um, inpatient rehabilitation in the hospital, it's usually 90 minutes. And 90 minutes is a good time. It's the average time for to have a very comprehensive evaluation. But we're going to discuss the other factors affecting that, the time for evaluation. In a skilled nursing facility, or what we call SNF, it can last from 60 minutes to 90 minutes. And I meant there 120 minutes, not 90 minutes. So 60 to 120 minutes. So I feel good to do evaluation within 90-minute range. So that is a good average time for me to complete my evaluation. Now, again, it is affected by or influenced by the complexity of the condition of your patient, how slow or how fast the patient moves. So some patient can not move very fast the way you want them to move. For you to assess the bed mobility, it takes them a lot of time or a lot of encouragement to get out of bed. So that is also a factor. The cooperation or behavior of the patient. So some patient, when they hear the word therapy, they will cuss out on you. They don't want to participate. Some of them who wants to really go home, well, oh, okay, you're the one I need. So they recognize that therapy will help them go home. So they will be more cooperative. The availability of documents, or the usual thing is for you to really review the chart first for, for you to know what's happening, what's the diagnosis, what are the precautions, what was the setup. Sometimes in the good documentation in the chart, you can find the prior living environment or setup of the patient. So it is ideal, it is very recommended for you to do the chart review first before you touch the patient, so you know what's happening. You can also save yourself from asking questions that's already available in the chart. So activity tolerance or rest periods needed. Some patients with CHF or congestive heart failure or COPD, they need extra time to move from one place to another. So you need to give them rest in between the tasks. So you cannot just, go, do this, do that. I need to evaluate this, I need to evaluate that. If the patient cannot keep up with your pace, it's not going to be a good rapport between you and the patient. So you really have to adjust to how the patient is moving. The patient should not adjust for you. Okay, so, and the type of software being used. So, what kind of platform or software or documentation system your company is using. So some software is more demanding than others. They're more detailed, and some are simple, so there's so many factors affecting the time. But again, it can vary from 1 hour to 2 hours. And for me personally, a 90-minute evaluation is a good average to see what the patient is doing and how the patient's moving. So these are, in general, the parts of evaluation. And again, it depends on what documentation system is being used. So the history of present illness, the past medical history, medications, prior level of function, discharge environment, the precautions, the current level of function, standardized test, short-term goals, long-term goals, frequency of treatment. So this is just in general, and again, usually this can be found in Kasamba. So the Optima also can have other parts there that might not be here, or the Epic also focuses on other things, other than listed here. Okay, so this is just like an overview in general of the usual things that are needed for you to document your evaluation. So the history of present illness, usually you can see that in the chart. It's written there why the patient went to the hospital, what is or are the causes of hospitalization, what happened during the course of the hospitalization. And this is just a summary. You don't need to write a novel about it. So, for example, you have, this is a 65-year-old female recently hospitalized due to a fall, status post open, reduction internal fixation of the right hip, and things like that. So that is the history of present illness. Past medical history, you can also find this in the chart, the list of all the comorbidities or the conditions the patients have. And it is also important to ask for the history of fall. So patients who have fallen before has increased risk of falling again. So did you have a fall within the past 12 months? It's a good question to ask. Medications can also be found in the chart. And the medications, 4 or more medications, we call that polypharmacy. And that is also related to increased risk of falling if the patient's taking so many medications. The prior level of function, we're going to discuss that in detail in a little bit. The discharge environment, also precautions. The current level of function, we're going to discuss this also in the following sections, okay? So why is the prior level of function important? The prior level of function give us a clear picture of what the patient was able to do, ideally within the past 6 months prior to hospitalization or being referred to therapy. So, it's important to know, was the patient using a walker or a cane, or was the patient ambulatory without any assistive device? Was the patient independent with activities of daily living, such as, dressing, going to the bathroom, getting in and out of bed, and, things that they do in a day-to-day activity? Or do they need assistance from a family member or caregiver? Why are we asking these questions? Because the prior level of function is actually our roadmap, quote unquote, for developing goals that are realistic and relevant to the patient. So if the patient has been like wheelchair bound for a year, it's not a realistic goal for you to have a long-term goal, for example, for the patient to walk 300 feet with front-wheeled walker, So, and you also have to ask the patient, what is the main goal of the patient? Some of the patients are realistic that, I was using a wheelchair before, I just want to use the wheelchair and be able to transfer myself safely from wheelchair to the toilet or wheelchair to bed. Some patients may actually not, but be realistic. Oh, I want to walk again, but they have not been walking for a year or two. So we want to honor their wishes, but also we want to be realistic on what are the things that they were doing before and what are the things that we see potentially that they can do again. The prior level of function and the goal setting, it is influenced or depends on the current status of the patient or the change of the condition of the patient. So in goal setting, you have to consider, was the patient ambulatory without assistive device before, but the patient had a massive stroke? So do you think for a short-term or long-term goal, it will be safe for the patient to walk without any assistive device? So although we have a prior level of function, we have to consider what is the change in the condition of the patient, and consider that in making the goal as well. So the main goal as therapists, our main goal is to bring back the patient to prior level of function or as close to prior level of function to decrease the burden of care. The discharge environment. So the discharge environment is a big consideration for goal setting. So does the patient need to navigate the steps or stairs as the prior level of function? For example, the patient was living in a house and the patient has 4 steps with 1 handrail. So is the patient being discharged to that house, or did the family decided to place the patient in assisted living facility or a skilled nursing facility? So having a goal of doing the stairs is no longer relevant to the discharge environment if the patient is not going home. So, but you can still use the stairs for strengthening of the legs or improving the endurance or activity tolerance of the patient, but no longer a target goal because the patient will no longer be discharged to home. So that's why it is important for us to ask the family member or ask the patient what is the plan. And if it is not established during evaluation, it's okay. We can always adjust the goal setting along the way. Also, planning for discharge, what assistive device the patient may be needing. So it's just like a projection, looking, ahead. So if the patient, for example, was ambulatory without any assistive device before, but the patient had a stroke and now has a left-sided weakness, will the patient be able to walk without assistive device, or later on will be needing being in a wheelchair because the patient is flaccid? So this is just to prepare us in planning in the future. So we ask this during evaluation: do you have a wheelchair, do you have a walker or a cane? So that during discharge planning, if the patient already has a walker or cane, and then we don't need to order those devices for the patient. Also, will the patient have a caregiver or will the patient live alone? So again, this will affect our goal setting. So if the patient will be living alone, the patient should be able to transfer himself or herself safely from bed to wheelchair to the toilet. Or if the prior level of function is that the patient has a 24-hour caregiver who assists the patient in different tasks inside the house. So our goal will be maybe contact guard or standby assist to the highest level that the patient can do, even with the caregiver. And we have to see, less barriers for discharge. For example, the patient needs to do 12 steps to go to the second floor because that's where the bedroom is, and there's no bedroom in the first floor. So again, that is a barrier for patient to be discharged right away from the rehabilitation unless the patient is able to safely go up and down the steps. And if this is no longer possible, then we will have a discharge planning with the patient. Is it possible for you to transfer the bedroom to the first floor so that you no longer have to do that 12 steps? Okay, so that is why it is important for us to ask the discharge environment of the patient. So next is the precautions. So the precautions can include a lot of things, and I just listed some of the common things. Fall risk, so if later on we're going to discuss the standardized test, and based on the standardized test and your observation as therapist, if the patient is fall risk, you have to put that on the precaution. The C. diff, we call it Clostridium difficile or difficile, however you pronounce that, we call it C. diff. It's like the diarrhea, but it's very infectious. So you have to put, gloves. Some facility really is very precautious about it. You have to put gown and gloves on if the C. diff is very active, and the patient cannot go out of the room unless the patient got cleared by the doctor. So, and the mask, so this is where you put the gloves, the mask, and the gown on and treat the patient inside the room. And you have to put this in the precaution. So whoever therapist is going to treat the patient next will know the precautionary measures that they have to do before entering or treating the patient. The droplet precaution, usually if the patient had pneumonia, or active respiratory infection, so you have to wear masks, especially if you feel like you're getting sick, and just to protect yourself from the droplet. When they cough, make sure it's not, you're not inhaling the droplets that they're producing. Another biggie is the weight-bearing precaution. So you have to put the weight-bearing precaution. This is very common among patients with hip surgery, hip replacement, or knee surgeries. I had a patient yesterday in an inpatient rehab in the hospital. Like, the left is weight bearing is tolerated. The right leg is toe touch. The left arm is full weight bearing, and the right arm is non-weight bearing. So they're like all extremities are listed what precaution it is. The patient had motor vehicular accident, so there are so many fractures all over the body, so that's why there's so many precautions for different extremity. But it is important for you to know if the patient has weight bearing precaution, so that when you're transferring or going to stand the patient, you know whether the patient can put full weight or half of the weight, or just toe touch in one or two or both of the extremities. So you have to look at the precaution before you treat the patient. Is the patient has a choking, precaution, seizure, behavioral deficit, can the patient be aggressive, oxygen supplements, some patients, especially patients with COPD, will be needing 2 liters, 3 liters, 1 liter of oxygen supplement. You have to monitor their saturation during therapy. Pacemaker or defibrillator, the patient should, this precaution should be written down, because in this kind of patient, you cannot use electrical stimulation or the diathermy for them, because it will affect the functioning of the pacemaker or defibrillator. So be sure to know the precautions of the patient when you evaluate them.